Thank you to Jen and Rena for the invitation to talk in this great session. As she mentioned, my topic today is CT of upper GI emergencies, for which I have no disclosures. I think this is an important topic because the esophagus and duodenum in particular are easy to overlook on imaging, the stomach occasionally as well. And so in this 15-minute talk, I'm going to talk about some common and some less common conditions with an emphasis on CT findings because today this is how we encounter these patients rather than the fluoroscopy department. And I'd like to share with you some challenging cases that have taught me lessons over the years. So I'll start with this patient here who came to the emergency department with chest pain, coughing, and fever. Our attention was naturally drawn to a process in the left lower lobe, which has cavitation, ground glass, and tree and butt opacities with a gas fluid level. And we thought that this might be due to an aspiration pneumonia with an associated abscess. The reason why this fits into this particular talk is take a look at this patient's esophagus. There's wall thickening, there are sort of contained pockets of gas and fluid along the wall that are consistent with ulceration, and suggesting this esophagitis alters this patient's workup because we know now why she was having aspiration and pneumonia. Unfortunately, CT is not terribly sensitive for esophagitis, about 55% in at least one study. But remember, when you see wall thickening in the esophagus, it should draw your attention. Usually the esophagus has a very thin wall, even when it's non-distended. And so if the esophageal wall is more than 5 millimeters, you might at least think about esophagitis, especially when diffuse. When there's submucosal edema, that can result in a target sign. However, there's a large overlap among etiologies. Thank goodness we are not performing double contrast barium swallows in the emergency department. I think if oral contrast delays a patient's disposition by 45 minutes, this would probably be substantially longer. But in the old days, when we were doing these more frequently, we could determine the size of the ulceration or the number of ulcers or the presence of plaques to determine a possible etiology. In CT, we get mostly wall thickening. And so while we cannot be specific about the cause of etiology sometimes, we can certainly diagnose esophagitis on CT. The presence of ulcerations is not always possible to delineate, but certainly possible to see occasionally. This patient, on the other hand, we're perhaps more accustomed to seeing on CT. This is a patient with epigastric pain, a very distended stomach, and a focal outpouching from the lesser curvature with disruption of the normal mucosal enhancement, submucosal edema, and actually active bleeding due to their peptic ulcer disease. And so remember that peptic ulcers can be visible even before they perforate, and we should be looking for them in the lesser curvature of the stomach in particular. This is a more subtle case of peptic ulcer disease, but an important site nonetheless. This is a patient who also has epigastric pain, but in this case, the ulcer is arising from the proximal duodenum. One very important point that I like to teach to my residents is that the vast majority of peptic ulcers in the duodenum occur in the proximal or the proximal portion or the bulb. The overwhelming majority of these ulcers are benign, and sometimes these can be confused for duodenal diverticula. Again, those usually occur more distally. Groove pancreatitis could potentially occur here, but there's gas within it conveying communication with the lumen. Again, the proximal duodenum is a very important site to interrogate for possible peptic ulcer disease. Contrast that last patient with this one. This patient also has epigastric pain. They have gastroesophageal reflux. We can see some nice thickening and targetoid appearance of the distal esophagus. The gastric folds look thickened. And notice that there is some ulceration within the distal duodenum and some wall thickening and possible ulceration in the proximal jejunum. This is not a typical distribution for peptic ulcer disease. This is very distal duodenal and jejunal ulceration with the ancillary findings of gastritis and esophagitis. And for the observant members of the audience, perhaps you notice this hyperenhancing nodule near the pancreatic head. So this is a patient with Zollinger-Ellison syndrome. We should think about Zollinger-Ellison syndrome and Crohn's disease when we see distal duodenal ulceration. The CT findings of Zollinger-Ellison syndrome include gastrin-secreting tumors, so look in the gastronoma triangle in the right upper quadrant, and also gastritis, esophagitis, and again, multiple post-bulbar duodenal ulcers. Here's another patient with an ulcer. I find these cases to be tricky. This is a diagnosis mentioned by Dr. Yu in our first lecture. This is a patient with a gastric bypass anatomy with a gastrojejunostomy. And notice at the staple line, there's a focal outpouching, a projecting into the left hemiliver. In my experience, I've seen a few cases like this that often make us think of a primary hepatic process because they often occur near the edge of the liver. But in this case, the deeply penetrating marginal ulcer at this anastomosis is causing inflammation and a perfusion abnormality in the left hemiliver. Think about these in patients who have had either a Billroth 2 or a Roux-en-Y gastric bypass. They occur at the suture line, usually at the jejunal side. They can grow to be quite large, such as in this case here, again projecting into the left liver, and they usually happen about 2 to 4 years after surgery. Shifting gears a little bit here, this is a patient with a very distended stomach, came in with vomiting. We notice a transition point to decompressed duodenum near the pancreatic head, where there's a focal enlargement and a hypo-enhancing mass. This is a patient with a new diagnosis of pancreatic adenocarcinoma, presenting with gastric outlet obstruction to the ER. Malignant gastric outlet obstruction occurs most commonly with gastric and pancreatic cancers, but remember, less common entities include lymphoma, primary tumors of the duodenum, and biliary tumors such as gallbladder cancer. This is a patient with gastric cancer, which was unfortunately already metastatic at the time of presentation. But again, notice the marked distension of the stomach and vomiting was their acute presentation. Here's a patient who doesn't seem to fit into this talk. This is a patient who has inflammation in the right upper quadrant. There's a non-calcified stone within the gallbladder. The gallbladder is not distended, but there is some fat stranding, and so we thought this was a case of acute on chronic cholecystitis. The patient was managed conservatively and came back several years later with this CT. Notice that their stomach is distended, similar to those other cases. The proximal duodenum is tethered to the gallbladder fossa, where the gallbladder is collapsed, and there's heterogeneous material within the lumen of the stomach. And this is a case of a patient whose chronic cholecystitis resulted in a fistula to the duodenum, causing gastric outlet obstruction, and this is a case of Boure syndrome. Think of Boure syndrome as a subtype of gallstone ileus. It results from a fistula between the biliary tree and typically the duodenum. That fistula can sometimes be visualized. Other times you may just see gallstones in the lumen, a gastric outlet obstruction, and a collapsed gallbladder. Here's another distended stomach, but not the same anatomy. This patient has an intrathoracic stomach that is distended. There's a transition point near the hernia neck, and there's an organoaxial or flipped rotation of the stomach in this patient with a clear case of gastricvolvulus, perhaps easier to appreciate on this cine image, which again demonstrates decompression of the obstructed stomach at the hernia neck and an abnormal lie of the greater curvature of the stomach above the GE junction. As far as gastricvolvulus signs on CT, remember that gastric distension is an important feature, but in patients who are actively vomiting or have an NG tube that's been partially positioned in the stomach, they may be decompressed. So we're looking for a transition point near the pylorus and stenosis at the hernia neck. If you give oral contrast, it should not pass beyond the gastric outlet. A non-passage of a nasogastric tube beyond the GE junction can sometimes be a helpful sign. And remember that similar to small bowel obstruction, ischemic signs such as surrounding fluid, fat stranding, and pneumatosis are specific but not sensitive. I mentioned one type of gastric volvulus in that first case, which is organoaxial volvulus. This is the counterexample of someone with mesenteroaxial volvulus. Notice that the stomach is below the diaphragm. There's no diaphragmatic hernia. There's an abnormal J shape to the infradiaphragmatic stomach, but still gastric distension, still a twisted rotation along the short axis of the stomach, and again, distal esophageal wall thickening from vomiting in a patient with mesenteroaxial gastric volvulus. Some important points that have taught me some lessons over the years is that gastric volvulus really requires at least 180 degrees of rotation and gastric outlet obstruction. And so when you see this patient who happened to come through our GI fluoroscopy department as an asymptomatic outpatient, They do not have gastric volvulus. They have a largehiatal hernia with organoaxial rotation of their stomach or positioning of the stomach in an organoaxial fashion, but they do not have gastric volvulus. So how does gastric volvulus happen? It's thought to occur because of two different mechanisms. One is an incarcerated hiatal hernia, which may include only part of the stomach. They may or may not have gastric outlet obstruction because of volvulus or simply have incarceration. It also can occur because of gastric redescent, meaning they have an intrathoracic stomach and part of the stomach comes back below the diaphragm, leading to a tighter hernia neck and obstruction. So let's look at a couple cases. This is a very noisy, non-contrast image in a patient who presented for a CT colonography. They have a large hiatal hernia and their stomach is entirely within their chest, but not causing them any issues right now. This is several years later when the patient presented with vomiting. Notice that now the gastric fundus is below the diaphragm, the entire stomach is distended, there's a transition point at the hernia neck, and so this is a patient who has gastric volvulus now because of redescent of the gastric fundus into the abdomen. Here's the opposite case. This patient came into the ER. They have a large hiatal hernia. Their fundus is below the left hemidiaphragm. We called this gastric volvulus because we were concerned about this transition point near the hernia neck and the gastric distension. This is their upper GI series that occurred 2 days later after their symptoms resolved. So the stomach is back up in the chest. They are no longer vomiting. They are no longer in extremis. And so this is a dynamic process that sometimes can be tricky when you only get one snapshot in time. Of course, an incarcerated hernia, although this is not an example of gastric volvulus, certainly is a very important and critical diagnosis. In this case, there's an ischemic gastric fundus that's herniated into the chest. But note also that there is pneumatosis within the gastric wall and extensive portal venous gas in a person who now has a necrotic stomach secondary to an incarcerated hiatal hernia. Of course, this is what we're trying to avoid. In addition to identifying ischemia, we also want to note patients who have evidence of perforation. This is a patient with an intrathoracic stomach. We've given oral contrast here. There's a large gas, fluid, and contrast collection in the right pleural space, and so this patient has gone on to perforation due to their gastric volvulus that undoubtedly resulted from ischemia. I'm shifting gears a little bit here to my last major topic, which is that of hemorrhage. This is a patient who presented with hematemesis. Notice the large amount of high attenuation fluid in the gastric fundus. So this is blood that is gathering within the gastric lumen, and the cause is another case of peptic ulcer disease. Notice again disruption of the mucosa, focal outpouching, gastric wall edema, and active extravasation resulting from this ulcer disease. This is a more subtle case of the underlying cause, perhaps because there's not active extravasation. But again, notice this patient has a large amount of high attenuation material in the stomach. They are cirrhotic, they have an enlarged spleen, and esophageal and gastric varices as the underlying cause of this hemorrhage. Sometimes we have to identify hemorrhage, though, that is not readily apparent either with blood in the lumen or active extravasation. This is a patient who presented with hematemesis. They have a very thickened upper esophagus, a focal outpouching from the aorta, and this patient has an aortoesophageal fistula resulting from this esophagitis that we have to infer just based on these findings. Again, a focal outpouching of the aorta towards the esophagus is helpful, as is adjacent esophageal wall thickening, extramural gas, and potentially an underlying cause. This is another example of an aortoesophageal fistula that showed oral contrast layering on an endovascular stent in the aorta. The counterpart for this disease in the abdomen is the aortoenteric fistula. Note this person's had an open aortic aneurysm repair, there's thickening around the graft, the duodenum is tethered to the aorta with loss of a fat plane, there is no active extravasation, however. So you should think about aortoenteric fistulae in patients with open AAA repairs. The CT findings include disruption of the aortic wall, loss of the fat plane, usually between the transverse duodenum and the aorta, fluid and gas around the aorta, but be cognizant of someone who's had recent surgery, as that may be a postoperative finding, and potentially pseudoaneurysm formation, active extrav being rare. So to conclude, we usually encounter upper GI emergencies on CT these days. So our job is to recognize these entities that can cause this presentation and identify the underlying cause when possible. Thanks so much for this opportunity to talk to you today.